The next case or the next topic that I want to cover is called do we need 3D? You know, there's a lot of discussion whether or not 3D is something you have to have, and should you buy a machine that has a 3D feature or not. And I will just give you my take on this, and I will present you a case, and I will show you a patient, and then we can discuss whether or not you think 3D really has an advantage or not. Okay, so I'll switch to this right here now. This is a patient who came to our lab with image quality which is not really very good, as you can clearly see here. This is a parasternal long axis view. I don't know if you see what the pathology here is. Very difficult to see. Focus on the mitral valve. You have the impression that there's a prolapse here, and when we turn on the color, truly there is some degree of mitral regurgitation where it's quite difficult to say in which direction the jet really goes. Remember, not all of our patients have terrific image quality, and I want to show you the cases how they really present in clinical practice and show you the advantages and disadvantages, and up front also show you how we can still solve problems even if we don't have such good image quality. Now this is a 4-chamber view. Again, the mitral valve looks kind of awkward. The right ventricle looks strange, but it is normal. The reason it looks strange is simply because the transducer was placed a bit far too apical. So this right ventricle just looks as if it is abnormal. Here's the parasternal the apical long axis view, and again we have the impression that the mitral valve is somehow prolapsing here maybe, but with color again we see mitral regurgitation. So if you want to communicate the problem and quantify regurgitation here, it's quite difficult. So in essence, we're stuck with a situation where we have a patient with a systolic murmur, where we, oops, this is a wrong loop, where we have maybe slightly dilated left ventricle with normal to maybe hyperdynamic function, with some degree of mitral regurgitation. And to really elucidate and find out what the problem is, we thought we just needed more information, and this could only be provided in this patient with a TE study. Now, this is actually something very rare, because in most cases, I would say, you can really clarify the mechanism of a mitral valve pathology from a transthoracic approach. But in this patient, it was just not possible. Will 3D help us here? The clear answer is no. Why? Because you can only get good 3D images if you have good 2D images, and this is not the case here. So we have to go one step further and perform a TE study. And I'll show you the TE study here. 1 second. Here we go. Or no, what I'll show you first is I'll show you the 3D studies, and then we'll discuss the pathology, and then we'll go back to the 2D study and correlate the two. Okay, this is a so-called surgeon's view. In other words, we're cutting through the left atrium and looking towards the mitral valve, down towards the ventricle. So we can see the mitral valve in a way that a surgeon could see it. Well, as a matter of fact, we see it even better than a surgeon for a simple reason. We are able to see the valve moving, because when the surgeon obviously opens up the heart, he cannot see it moving. I hope not. Okay, so what do we see here? We see the mitral valve, and it's quite nice to discern, or easy to discern, the posterior leaflet, which is this leaflet here, and the anterior cusp, right? So these are the two leaflets, posterior and anterior. One first thing which is always important, how can one really understand where is up and where is down? Because it depends very much from which position you transduce image and how you reconstruct the 3D image. There's a little trick. Use two landmarks. One landmark is the left atrial appendage, right here, and the other one is the aorta, which is not on here for some reason, but it's probably right here. And usually, both the aorta and the left atrial appendage are closer to the anterolateral commissure versus the posterior medial commissure. So you kind of know that this is top and this is bottom. Okay, and to differentiate between the posterior and the anterior leaflet, It's also very easy if you remember anatomy, and if you remember that the posterior leaflet takes up more of the circumference of the ring, and it is shorter. So in other words, you can see the posterior leaflet is much shorter than the anterior leaflet, which has more, I would say, a quadrangular shape, or maybe triangular shape. So this is the anterior leaflet, which is longer, and the posterior is shorter. But let's go back to the pathology. So if we look at this 3D image, what we see here is we see a part of the posterior leaflet which prolapses, right? And then you've got a hole in here. I'll stop the image here, 1 second. Okay, I'll just go back and forth. See, you see this hole here? Now, you will probably think, well, this must certainly be a perforated leaflet. But I can tell you, no, it's not. The reason why this leaflet looks like there's a hole is very simple, because we have a cut plane which simply just cuts part of this prolapsing part of the leaflet away. Because if you go back and you look at a different frame, all of a sudden there is no hole here. So this is one of the pitfalls, or one of the problems that you are confronted with if you perform 3D. But the nice thing is that you can really see that it's the medial part of the posterior leaflet that is prolapsing. This is the problem here, right? And if you look closely, you have a structure right here. And you might think this is an artifact here. Again, you see? Oops, here we go. Here we have it again, this structure. But if this is an artifact or not, we can then determine if we look at the 2D study. So very nice. We can communicate this information with the surgeon, say, listen, the problem is right here in what we call P2, and it must be the posterior leaflet. Okay, now let's go to here's again another study. Again, we have this structure. So if you do 3 or 4 3D loops and then you find the structure always present, then it is usually not an artifact, but it must be a real structure. Now here is the corresponding 2D study. Okay, here's the TE, and you all agree, in essence, to make the diagnosis of a prolapse, you do not really need 3D. I mean, you have the posterior leaflet prolapsing here, and if you look very closely, you will also see that there's a very small portion of the posterior leaflet here. You see this? That is kind of flail, and this was the structure we saw right here. Let me go back to this. Remember, this is the structure we see right here. So you see how many details you can actually get, but in essence, and this is maybe the key message that I want to give you, everything that is seen in 3D must also be visible in 2D, otherwise you cannot reconstruct it. So if you are very good at imaging, and if you're very good at putting everything into like a mental reconstruction, you can get a very good understanding of what is really going on. But if you want to show it to someone, for example, a surgeon, or maybe get a better understanding of the true dimensionality, 3D is certainly superior if you have good image quality. Okay, so this is just an example of what 3D can really do. And just to show you the severity of mitral regurgitation, conclude the case, yes, I would say it is severe. You have a lot of flow convergence, so on. It's not severe, it's probably moderate to severe, I would say. And certainly this is a patient that you'd have to follow up and see if the ventricle starts to deteriorate or dilate, or the patient gets symptoms. But at this point, he would not necessarily be a surgical candidate unless we think that the possibility of reconstructing the valve is very high. Because if this is the case, one could just go on to operate in even asymptomatic patients. This is big discussion in the community at the moment. Should one operate if a patient is asymptomatic or not? Okay, but I don't want to just go off into a different field, which is not my main topic. I want to maybe go back to the issue of 3D and show you some other case examples. Let's see if you are able to make the diagnosis simply based on the 3D image. This is a different patient, okay? Take a look at this valve. I will help you a bit. Here we have the anterior leaflet here again. This is the posterior leaflet. This here is, again, the aortic valve. Okay. Okay. I just got a question from Angel, or Aurel, excuse me, Aurel. The question was, is MR holosystolic? I think you meant the patient that we saw previously. Well, it was not, I mean, it was holosystolic, but I would say that most of the regurgitation was happening towards mid and end systole. This is something you see very frequently in the setting of a mitral valve prolapse because, you know, the valve loses coaptation more towards the mid and towards the end of systole. But coming back to this case here, I'm sure you can all appreciate that something is going on right here, okay? But how does this now look in 2D? This is the patient, all right? So you have a anterior leaflet, which is flail. You see that part of the leaflet is protruding behind the posterior leaflet. So if you kind of, you know, stop the frame, let me see if I can stop it here. No, I can't advance it. Anyway, if you take a look at this, the relationship between the anterior and the posterior leaflet, you see that part of the anterior leaflet is behind the posterior leaflet. This is what I call the parallel sign, which can only happen if part of the anterior leaflet is detached. And if you look closely right here, you would see the detached part of the leaflet. And going back to the 3D study, this is exactly what we see here. You see, this is the flail anterior leaflet. Okay, so you know, with a bit of practice, you can make the diagnosis out of 3D. But still, again, an example where I think the information you get the information you get from 3D must always be complementary. You should also look at the 2D study. Now, what about this pathology? This is a different view. This is a mitral valve that we're looking at now from the ventricle. In other words, we're looking up towards the mitral valve, and we can see kind of the clapping motion of the posterior and the anterior leaflet. Again, the larger leaflet here would be the anterior leaflet, and this here, which takes up more of the circumference, is the posterior leaflet. And it's difficult to see what the pathology is here. Probably more or easier if you look at the same valve now from the other side. Again, we have the aortic valve here. And right here you see the anterior leaflet and the posterior leaflet. It's very difficult to really see the posterior leaflet. It kind of appears to be very small. The question is this a coaptation defect, or is this just a dropout that you have? I would probably think most of it is just a dropout. But the key feature here is that this is a patient who has restriction of both leaflets. What does that mean? It means that the mitral valve is kind of pulled towards the ventricle, and thereby we have restricted leaflet motion. In other words, leaflets cannot coapt, and therefore we have regurgitation. And what we see in the 3D image is just that. We see that the posterior leaflet is kind of drawn towards the left ventricle, and therefore we only see kind of the basal part of it. The apical parts of the leaflet, or the ventricle parts of the leaflet, or the tips of the leaflet actually, are drawn into the ventricle. All right, here again, this is the view from the apex. You see the position is as if it is just not moving. Okay, so with a bit of practice, you can even see leaflet restriction with the help of 3D echo. But if you want to have my honest opinion, I think it's easier to see restriction on a 2D image. What about this patient here? Here we have, again, the aortic valve. In other words, this must be the anterior leaflet. This is the posterior leaflet. And then we have this structure here, which kind of swings back and forth. What do you think this is? Well, this is a posterior flail leaflet. Very nice to see. Again, you see the posterior leaflet, which extends behind the anterior leaflet. Now, these are TE studies, but they are sometimes very good to understand because it also helps you when you are trying to interpret transthoracic studies. Okay. I got a question in from Stavros. A flail mitral leaflet isn't an indication for surgery. In other words, Stavros wants to know if all patients who have a flail leaflet must be sent to surgery. Well, the answer is very clearly no. It depends on the severity of mitral regurgitation, because there will be flail leaflets where you don't have very much regurgitation. And the second issue is if the patient is well adapted to volume overload and he's asymptomatic and the ventricle is doing fine, you can still perform what we call watchful waiting. In other words, we just follow the patient up, and once he gets symptomatic and once the ventricle shows sign of deterioration, operate him then. There's been plenty of studies that have shown that this approach is pretty feasible. So a flail leaflet does not always mean that regurgitation is very severe. Okay, now this is another image. You see, this is a very typical image you get with 3D. It's not always, you know, the super quality that one expects. Here in this case, it's a lot more difficult to really see what the problem is. Okay, let's go to the 2D study and look at it more closely. This is now the ventricle, the mitral valve from the ventricular side. Okay, this kind of looks very strange here. What is this here? This blob, right? Let me go back to the left atrial view. Okay. Okay, I see that we have Philippe here, who has been with us on several occasions, and he's an expert, I know, because he already realized what the problem here is. We have two orifices. Look at this. This is one orifice here, and this is the other orifice. And this is something that holds the two leaflets together. If we go back to the view from the left ventricle, here you see, again, the two orifices. One is here, the other one is here, and then this blob here kind of puts these two leaflets together. And this is a patient who has a mitral clip procedure. It's very similar to the Alfieri stitch that Philippe thought it was, and he's correct. It looks very much the same, only that with the mitral clip procedure we perform clipping of the anterior and the posterior leaflet from an trans or percutaneous approach. In other words, it's a semi-invasive technique. It's a new technique that we use to treat patients with severe mitral regurgitation, where we kind of place a clip between the anterior and the posterior leaflet to tie these two together and therefore resolve mitral regurgitation. And here is the study, the 2D study. You have the clip here in the middle, and you have two orifices where you have blood flow going in, and some degree of regurgitation, which is still present. So this is a mitral clip procedure. So in essence, you see that 3D is a real neat thing, and I think if you look at the morphology of the mitral valve, it does help you, especially in situations where you're planning surgery or where you're trying to understand what the extent of a lesion is. But again, remember, I think it should be always looked at in conjunction with conventional echo, with transthoracic, but also with T. Good. Okay, so this was a little mini lecture